Good afternoon to everyone present here with us today. This is Shreyan from IJCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Urman Dhruv. Sir is MBBS, MD Internal Medicine, Director, Internal Medicine and Diabetes at HCG Hospital, Ahmedabad. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is GLP-1 era rethinking healthy weight management in 2025 and 2026. Now, without any further delay, let me welcome Sir again at our forum and would like to hand over the session to him. Over to you, Sir.
Thanks a lot. Thanks, IJFCP, and thanks to everyone who has joined. I hope I'm audible and visible, Sriyan.
Yes, sir, perfectly audible and visible.
Okay, so we move ahead, and this is Dr. Dhruv greeting you all and coming to you in next 30-35 minutes. GLP-1 era rethinking in 2025 and 2026. The disclaimer is there that the presentation and the talk may not be all inclusive, and for any decision making, it is always mandatory to get the authentic academic support. This is how we are going to talk about. You can call this my agenda for today's topic, and let's start. Why do we go on talking about obesity these days? On and off. Every conference of diabetes is now getting converted to diabesity. The reason is the prevalence is rising world over. Obesity is now, without any doubt, the major driver of diabetes, cardiovascular disease, and now add to it NFLD, which is now MASLD, and high healthcare and economic burden. 1 billion globally, and when we look at India, the diabetes and obesity link is rising in urban areas, and even the age group is changing. From what we used to see after 40, now we are seeing about 25. And we all know it's a chronic relapsing disease, biologically defended condition. We know one more thing now, that it is neurohormonal adaptation that is promoting the regain of weight which is lost in obesity with the help of lifestyle modification. So, whatever you do, it requires long term management strategy. This is what we had been doing 5 years back. As you can see on the right side, lifestyle changes, medical nutrition therapy, behavioral changes, at the most metformin and SGLT2 inhibitor. GLP-1 receptor agonist. What does it do? It completely changes the scenario. Why do we rethink weight management? Number one, the direct trial carried out in 2014 taught us that there is something beyond calories, and that is hormonal dysregulation is the key driver in obesity. In 2025, last year, WHO came out with a guideline suggesting that use in multi-modal program to control the obesity. And we also realize that GLP-1 receptor agonist not only target the gut, but it targets the brain also. And that's how we could find out brain-gut link. Why GLP era matters? We all know obesity is a chronic disease. We also know the limitation of lifestyle only approaches, although the direct trial showed a reduction of 15% weight. However, it was not sustained with lifestyle only. So we know lifestyle can achieve 15% weight loss, but it cannot maintain it. And there came the pharmacological revolution in last 2 years. GLP-1 receptor agonists represent a paradigm shift in healthy weight management. Remember why we are calling it healthy? Because lots and lots things have been used for weight management, but none was healthy. So, this is one which is causing healthy weight management, offering a substantial weight loss alongside metabolic benefits in the current years. What is GLP? It is a hormone secreted from intestinal cells. It has glucose regulatory effect. It mimics the gut hormone GLP-1 to regulate blood sugar and also to regulate the appetite. And so it enhances the satiety and slows the gastric emptying. This is how it works. When you have a mixed meal, intestinal GLP-1 is released, GLP-1 becomes active. No sooner it becomes active, immediately DPP4 enzyme kills it into an inactive form. And that's why DPP4 inhibitors can prolong the effect of GLP-1. Then what does the GLP-1 receptor agonist do? This is the physiology of GLP-1, but we add pharmacological doses of GLP-1 from outside. So it does everything that a natural GLP does, starting from secretion, absorption, and suppression. Very classical gut brain axis, which is bidirectional. And you can see on one side, the brain gives signals from nutrient delivery, changes the microbial balance in the gut, changes the motility of the gut, and also changes the secretion of GLP-1. And that GLP-1 acts on gut and brain again. On the other side, the GLP-1 also acts on the anxiety, mood, stress, and they all act on brain. So, as you can see, GLP-1 is a key incretin signal which regulate the hormones of hunger and satiety. Why does lifestyle alone often fails? We all have tried to control our weight through lifestyle, exercise, diet, and whatnot. But there are metabolic adaptations, so energy expenditure gradually decreases. With the same amount of exercise, what you can do is kill or destroy 100 calories. With the same amount of exercise, after 6 months or 1 year, you are able to destroy or kill or spend only 80 calories. So there are metabolic adaptations, high relapse rate in 1 to 5 years, and once the weight loss starts, hunger hormones start secreting and they increase your appetite and you start eating a lot. What does GLP-1 does? It targets the biological drivers of obesity, it improves metabolic efficiency, but most importantly, it suppresses the appetite centrally and also it causes the gastric emptying to be delayed. So, whatever food we eat stays in the stomach and so further food is not accommodated. GLP-1 receptor agonists act also on hypothalamus and appetite is suppressed, and that's how caloric intake is reduced. And all these things combined improves the metabolic efficiency. How does it suppress the appetite? GLP-1 receptor agonists act on hypothalamus, reduce hunger, and increase the fullness of the stomach. It not only does this, it alters the food preferences. So now you have less fat craving, you have less sugar craving, and so there is a distance from certain food which were your favorite 5 years back. This happens all through neurotransmitter modulation for sustained satiety. How does it act on gastric emptying? Powerful gut effects. The brain, hypothalamus, releases hormone and it acts on stomach, slows gastric emptying, prolongs fullness post meals, enhances insulin secretion. Very, very important in controlling diabetes through GLP-1 and suppresses glucagon. Don't forget this word. It suppresses glucagon. And we'll see what are the limitations of GLP-1 and suppressing glucagon is one of the important limitation of GLP-1, and that's why we needed something else. The gut hormone synergy improves the metabolism. So don't forget from this slide that GLP-1 receptor enhances insulin secretion but suppresses glucagon. It also acts on brain reward system. The brain rewards the self after meal even though you are full. Brain gives reward for the same. But as the days pass, brain stops giving reward in the same amount. So first, when you used to eat ice cream following a meal, you were getting reward of presumably 100 hormone units. But once 6 months have gone, now you require 2 cups of ice cream for the same reward. And that's how the GLP-1 starts working everywhere. The GLP-1 receptor agonist overview. It is either available as long-acting injectable formulations or it is available as weekly dosing, and now in 2026 it is also available as oral GLP-1 molecules. Well, you will be surprised. You will be surprised to know that GLP-1 were already available in oral form. Yes, they were available for glycemic control. Now, oral GLP-1 molecules are available in higher strength for weight management. What does clinical trials show? It shows a weight loss of about 10 to 20%, much more superior to lifestyle intervention. 10 years back, I used to show the slide. Lifestyle intervention can reduce 5% weight, and that helps in so and so and so and so and so. But now we can say that the GLP-1 receptor agonist reduce the weight by 10 to 20% in dose dependent efficacy. Higher the dose of GLP-1, higher is the weight reduction. And this weight reduction is sustained, of course, as long as you continue the therapy. Let's look at the therapeutic point of GLP-1 receptor agonist. What are the approved drugs? Oral semaglutide, injectable semaglutide, and injectable tirzepatide. But I am sure at the end of 2026, the whole screen will be filled with many other drugs that we'll see. What was important, as I told you, shift from injectables to emerging orals in 2026 for weight management. So let's have a look at semaglutide first. A couple of slides. It acts only on GLP-1 receptors, causes 10% average weight loss, and therefore comparatively lower efficacy. So why do you need new molecule? I told you GLP-1 suppresses glucagon. What does GIP do? GIP and GLP have different effects. As you can see in the white fonts, GIP having a glucagenotropic effect and GLP-1 has glucagon-static or suppressing effect during hyperglycemia. So now, if you combine GIP with GLP-1, you have got a double role. Hypoglycemia, glucagon would be stimulated. Hyperglycemia, insulin will be stimulated. And that's how, if you combine both the molecules, you get terzepatide, which is a combination of double receptor agonist, which acts on brain by reducing appetite, reducing food intake, and causing marked weight loss. It acts on pancreas by secreting insulin, improves the insulin synthesis and beta cell proliferation. And it also acts on fat tissue for lipolysis and fatty acid synthesis that leads to significant visceral fat loss. What is the responder rate to terzepatide? High proportion of patients achieve more than 10% weight loss. You can in fact identify super responders who lose as much as 20% weight loss and a meaningful metabolic improvement. We'll see what is metabolic improvement. But tirzepatide causes weight loss with metabolic improvement. How long it is durable? It is sustained as long as therapy continues. At present, we have got data of 5 years. So, the chronic disease model of obesity is absolutely targeted at. However, one more weakness is weight regain after the discontinuation of the drug. Does body composition change? Yes. The weight loss is predominantly coming from the fat mass. Most of what you lose is the fat, adipose tissue, that to bed adipose tissue. Some lean mass reduction occurs that causes sarcopenia, means there is some muscle loss also that requires to be compensated with resistant training so that muscle becomes powerful. Effect on glycemic control, we all know them for years. We have been using semaglutide and tirzepatide for HbA1c control, significant HbA1c control 1 to 2%, lower postprandial sugar. Of course, it does not affect the fasting sugar because it has got a food dependent insulinotropic effect and reduces the need for insulin in some patients. Cardiometabolic benefits, because of improved glycemic reduction, blood pressure is also reduced, lipid profile improves, and weight mediated cardiovascular benefits are obviously seen. Acts also on liver. Inflammation in the liver enzymes may improve, and the role is under investigation. But this line needs to be changed. The terzepatide has come out with a large trial saying that it acts wonderfully well in metabolic liver disease. What are the metabolic benefits beyond weight loss? Lowers triglyceride, lowers LDL, reduces inflammation, less ectopic fat in liver and heart. So it actually reverses MASLD, better energy use, and obviously cardiometabolic improvements seen in trials. Safety profile. We all know we have been using both the molecules, mainly gastrointestinal adverse effects. They are dose dependent and transient. And if you start slow and go low, then you can control them very easily. 4 to 6 years of safety data is already available. As I told you, symptoms are common: nausea, vomiting, and constipation. Diarrhea is much less common. These are transient, occurs only for first month, and as I told you, minimized by slow titration. So if you start semaglutide at a slower dose and increase it only monthly, or tirzepatide in 2.5 milligram dose for 1 month, 5 milligram next month, 7.5 next month, then GI side effects do not trouble. There are certain serious side effects. One has to be careful if there is existing gallbladder disease because it causes gastric stasis. It can cause pancreatic signals. However, most of the trials have not associated the drug with pancreatitis. However, thyroid C cell findings are seen in animal data. So, what are the contraindications? Gastroparesis, a strong contraindication. Drug, pregnancy and lactation, you don't have to give the drug, absolute contraindication. Severe GI disease, not to be used. And most importantly, medullary thyroid cancer history or multiple endocrine neoplasm type 2, strongly contraindication. Which patients benefit? BMI more than 30 or BMI more than 27 with comorbidities, especially if you have motivated these patients for long term therapy. The last line is very important. You cannot ask the patient that we start the drug for 1 or 2 months and then we'll see. You have to tell them that you have to take the medicine at least for 12 months. So, while starting the drug, always share the decision making with the patient, show them the benefits and risks, set realistic expectation, explain the chronic therapy concept, at least 12 months, preferably 24 months, Don't allow them that it is going to reduce 20% or 25%. You have to tell 5 to 10% weight loss in first year. Initiation, start low, go slow, escalate gradually, monitor tolerance closely, and education patient proactively. GI side effects can be managed with antiemetics, lot of hydration, and fiber so that patient can have good GI tolerance. Monitor the parameters, look for weight and waist circumference regularly, look for GI tolerance and nutrition, especially because you have to add B12, you have to add enough of protein. Half the dish should be filled with protein, and of course, vitamin D and also the other micronutrients. You can use app based tracking. The patient requires monthly visit for first 3 months, where you will be looking for weight, A1C, and side effects. Quarterly labs required to be done, especially with semaglutide, because there were some problems of retinopathy. Annual retinal checkup and thyroid checkup is a must. And of course, don't forget hypoglycemia, because as the weight would be lost, glycemic control would become intensive. And so always look for sugars, HbA1c, or even 5 simple sugar or CGMS in diabetics. Lifestyle integration needs to be correlated, coordinated, combined with the drug. Nutrition therapy remains essential. No effort should be done to inform the patient that this is replacing the lifestyle. All efforts must be done to explain to the patient that this is in addition to lifestyle integration, resistant exercise to preserve the muscle, to tackle diabetes, nutrition counseling in the form of mindful eating, enough of proteins, stress reduction, good sleep, and you can utilize support groups for adherence to the treatment. Psychological consideration, body image, and stigma are important issues with the youngsters these days. Mental health integration is there, and eating disorder screening is a must. How can you emphasize the adherence and persistence? Cost and side effects are major barriers. Education improves the persistence. Despite all said and done, dropouts are higher in real world. The reason is high out of pocket cost, insurance coverage, access to treatment is unachievable, and equity concerns are there. Let's compare GLP-1 versus bariatric surgery. The outcome: average weight loss with GLP-1 is 10 to 22% versus bariatric surgery 25 to 35%. Diabetic remission. GLP-1 improves the chances of diabetic remission, but surgery most of the time causes diabetic remission at least for 3, 4, 5 years. Risk profile: GLP-1 mostly GI side effects, while surgery, it's operative, invasive, and nutritional risks are there. Cardiovascular benefits, much more proven, evidence based trials are there with GLP-1. Surgery, there are only observational studies as far as cardiovascular benefits, mass reduction, improvement in mortality due to heart attacks are concerned. And reversibility, of course, you can stop GLP-1 anytime, but you generally cannot revert most of the bariatric surgeries. Invasiveness, obviously, weekly injection versus major surgery. Recovery time is none with GLP-1. It may take 2 to 6 weeks bariatric surgery. Long term adherence, you require to pursue for GLP-1. On the other end, for surgery, it's a one time procedure. So GLP-1 versus bariatric surgery in nutshell: greater weight loss with surgery as compared to GLP-1, but GLP-1 is a non-invasive option, may act as a bridge or alternative to surgery with patient-centered choice. Special population: when you are addressing older patient with GLP-1, always think about sarcopenia and explain to the patient the risk of sarcopenia, including sudden fall and the need for resistance exercises. Adolescents, cautious use is needed. Avoid in pregnancy. Stopping the therapy. Recovery is common once you stop the therapy. So, plan exit strategy. Explain to the patient to continue vigorous lifestyle changes and then exit the treatment, not before 2 years. Lifestyle reinforcement is essential. Remember, if you are on terzepatide and you miss 2 or 3 doses at 7.5 or 10, then you have to go back to 2.5. So missing a dose requires to be explained properly, otherwise the whole treatment paradigm would go back. Indian perspective, in India, GLP-1 cost these days is 15,000 to 25,000 per month with weekly injections or tablets. Insurance cover is not there. Bariatric surgery is a one-time expense of around 5 lakhs, but access to GLP-1 may be limited, although now the CGHS provides semaglutide injectable. Still, affordability remains a problem. So, from Indian perspective, GLP-1 is ideal for those who are having 27 to 35 BMI with comorbidities like diabetes, hypertension, or coronary artery disease. Useful where surgery is contraindicated or declined, but if your BMI is more than 35, I would suggest to go for a short duration of GLP-1 followed by surgery. Of course, if there is associated MASLD or diabetes, GLP-1 requires to be used irrespective of pediatric surgery. Couple of trials, 3 or 4 slides. Step for semaglutide. It was a randomized double-blind placebo-controlled trial. Step 1 in non-diabetic patient. Efficacy 14.9% weight loss at 68 weeks. Remember, 68 weeks comes to around 1.25 year versus only 2.4% in placebo. So excellent efficacy, safety only GI side effects, and 86.4% achieved more than 5% weight loss, 70% achieved more than 10% weight loss, and 50% achieved 15% weight loss. So semaglutide was significantly good drug. Terzepatide trial Surmount, a 72-week trial, so nearly 2 years of trial in patients with obesity. These included even non-diabetic patients, and one can see with different categories of doses, the weight loss was different. With a minimum 5 milligram dose, 15% weight loss, up to 15 milligram led to 20.9% weight loss. Surmount also showed dose dependent large weight reduction more than 20% when the full doses were used and was reasonably safe. And it was carried out for CV outcome study, just like all other anti-diabetic drug. Semaglutide also underwent CV outcome. That was a select trial, and it showed that 2.4 milligram semaglutide reduced the cardiovascular death, non-fatal MI, and non-fatal stroke. So it is definitely cardiovascular benefit. What are the guideline recommendation? EASD, ADA, Endocrine Society now all advocate GLP-1 receptor agonist as number one drug except in diabetic kidney disease, where SGLT2 inhibitors still hold the fort. Pharmacotherapy as standard of care, chronic treatment framework, and this is what it does in pre-diabetes, in type 2 diabetes, in obesity with hypertension, in obesity with ASCVD, in obesity with heart failure with preserved ejection fraction, MASH, obstructive sleep apnea, and osteoarthritis. Everywhere you can see now that the guidelines show the role of GLP-1 receptor agonist. So, a very important molecule. What's the impact on health system? Reduced hospital visits, need to budget plan out, and potential long-term cost saving. Ethical considerations are still there. You need to avoid the stigma and fair allocation of resources. Emerging evidences, integration into chronic care model, but most important is real world data is now evolving after a lot of evidence based trials, now we are coming out with huge real world data. Couple of slides about future therapies. What is there in the pipeline? Dual and triple agonist, oral incretin therapy, precision obesity medication. We have got tescofensine, also known as NS2330, which acts as a noradrenaline, serotonin, and dopaminergic reuptake inhibitor and reduces weight significantly. Cannabinoid 1 receptor agonist, antagonist, already there, available, and we know already there in the market as amylin analog. Two important drugs that are already being approved by FDA. One is retatrutide, which is bound to come in 2026 to India, and then efoxipentaglutide. Both of them are triple incretin based therapy, and they actually cause glucagon receptor stimulation. And by stimulating glucagon receptors, they actually spend more energy for the same exercise. That's the effect of glucagon. Remember, glucagon is a catabolic hormone, while insulin is an anabolic hormone. So, by stimulating glucagon receptors, we are spending more energy for the same exercise, and that's how triple incretin based therapies work. And both these drugs are going to reach India by the end of this year. Pipeline, and that would certainly change the scenario in future. Not only that, these drugs are now being used for broader indications like Alzheimer's and for foot ulcers. There are certain research gaps like long-term safety data. We have got only 4 years data at present. Optimal combinations are not here, and hard cardiovascular outcome studies are coming at the end of this year. Challenges are there. Supply and cost still an issue. Mitigation, equity still an issue. But for Indian scenario, two important issues. One is counterfeits. They are already there in the market. So one has to be very much afraid of counterfeits. And the second one is muscle loss, which we, if we don't explain, can lead to tremendous harm to elderly patients. Call to action. How do we go ahead? Prescribe with lifestyle for 15 to 20% loss. GLP-1 receptor agonist in 2026. Monitor holistically, meaning thereby keep an eye on HbA1c, keep an eye on BMI, keep an eye on waist circumference, keep an eye on lipids, keep an eye on blood pressure, keep an eye on cardiovascular outcomes, and never forget to check retina. Time for all of us to rethink obesity as a manageable and a must targeted disease. We cannot leave obesity as a harmless condition. It's a chronic disease which requires very quick management. So, take home message: GLP-1 therapy has transformed obesity care, best used with lifestyle therapy. Evidence of superior efficacy and safety are already there with GLP-1 receptor agonist, multimodal for sustainable weight loss, suggested, and think them as hormonal game changer. These are few references that we have taken for, and that's where we'll stop. Thanks a lot. Thank you very much.
Thank you so much, sir, for this wonderful presentation. We did receive few questions. If you like to take that up.
Sure.
So the first question is: in which patient profiles do you see the maximum clinical benefit with GLP-1 based therapies?
Those patients who are having BMI between 25 and 35 with or without diabetes, those patients who are already having fatty liver, MASLD with them, those patients who are dyslipidemic, especially LDL is above 100 despite statin, and those patients who are younger between 40 and 60. These are four important group of patients where GLP-1 receptor agonists create a wonderful efficacy. Add to it, obviously, add to it especially the side benefit that is there along with GLP-1 receptor agonist.
Thank you, sir. There is another question, which is, are we shifting from BMI centric to metabolic health centric weight management in GLP-1 era?
It is not only cricket where we are shifting. In cricket, you are seeing suddenly the number of batsmen are going down and number of all-rounders are emerging. Even the all-rounders are getting more paid more than the opening batsmen. The same thing is happening in obesity and diabetes, where we are not using drug in diabetes which only reduce HbA1c. SGLT2 inhibitors are the one which act on kidneys, which act on weight loss. Similarly, in obesity, we have started utilizing drugs which not only reduce the weight, but also reduce the metabolic paradigm or the issues like dyslipidemia, blood pressure, can help the heart, reduce the episodes of heart attack, reduce the chances of heart failure. So starting from SGLT2 inhibitors, now GLP-1 receptor agonists, you are absolutely right in saying that we are no more weight centric, we are no more BMI. Forget BMI, probably next year BMI would be out. We'll be only talking about waist, height, circumference. So BMI is already out, but we are not concentrating now on weight. We are not concentrating on HbA1c. We are now concentrating on a big circle which includes weight, blood pressure, lipids, BMI, HbA1c, and so yes, we are shifting our concentration from BMI to metabolic improvement.
Thank you, sir. There is one last question. What are the most common adverse effect you encounter, and how do you proactively manage them?
We already shown in the slide only there are GI side effects. We have never encountered pancreatitis with these drugs, never, even in alcoholic patient, but I would be little careful in using it in alcoholic patients. Otherwise, commonest one is nausea, vomiting, and the constipation can be very easily taken care by adding isabgol or a lot of fibers, while the postprandial heaviness can be taken care with small feeds. Remember not to use the GI motility agent like domperidone in cases of postprandial heaviness due to GLP-1 receptor agonist, because you are utilizing an antagonizing drug. GLP-1 receptor agonists cause gastric stasis. By giving domperidone, you are increasing the gastric motility. So never use it. Instead, you can use evomin or you can use other drugs for GI stasis. But most important would be small feeds, 4 hourly feeds. Use less protein in each feed, but overall protein intake should increase. Use vegetables more, use fiber small. But the most important thing would be small feeds every 2 or 3 hourly. And of course, as I already told you, start low and go slow. Very small increments in the doses, whether it is semaglutide or tirzepatide.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. Before concluding, any take-home message from your end?
Right. Do
Am
we
I
have any
audible
other?
to you?
Yeah, now you are audible.
Yeah, I was requesting, sir, that as we are about to conclude, can you please give one take-home message for our audience?
Obesity is no more a stigma. Obesity is no more a condition. When you look at the patient entering your consulting room and he is obese, start thinking about how to explain, convince the patient for weight reduction. It need not be through the drugs, but weight reduction in an obese patient would prevent a future heart attack, a future stroke, a future left ventricular failure, a future diabetes. Multiple You are preventing multiple diseases by targeting the obesity first and have a goal of 1 kg weight reduction per month up to 15%.
Thank you so much, sir, for such wonderful session. It's a pleasure to have you here, sir. Thank you so much for joining us today. Thank you, sir.
Thank you, Sian. Thank you very much, IJCP, and thanks everybody.